Hello, everyone. I am Dr. Astha Dayal, and I'm the lead consultant gynecologist in 𝐃𝐄𝐓 Hospital in Gurgaon, and I welcome you all to today being World Cancer Day. I welcome you all to everyone's guide to know all about breast cancer. And we're going to have a panel discussion for everyone to have some insights about the burden of breast cancer in India and what should we do in terms of early detection, some sort of prevention, and what are the government policies that are taking place. And we have a very esteemed panel today. So I would first like to invite all my panelists for this discussion. We have Dr. Rupinder Sekhon. She is the Senior Consultant and Chief of Gynae Oncology at Rajiv Gandhi Cancer Institute and Research Center. And she's also the Vice President of Association of Gynae Oncologists of India. And she's the Chairperson of the Oncology Committee of AOGD in Delhi. Secondly, we have Dr. Ajay Gogia, who is an associate professor at the Department of Medical Oncology at All India Institute of Medical Sciences, AIIMS, New Delhi. We also have Miss Urvashi Prasad. She's the Director, Development Monitoring and Evaluation Office, DMEO, and NITI Aayog from the Government of India. Then we have Miss Ruby Ahluwalia. She's the founder and managing trustee of Sanjeevani, Life Beyond Cancer. We are also joined by Professor Dr. Malarvizhi K. Natarajan, who is the professor as well as principal of Hosmat College of Nursing, Bangalore, and Dr. Ranga Rao, who is the chairman of Paras Cancer Center, Paras Hospitals. He'll just be joining us in a few minutes. So I'm so glad to have all of you on the panel today. And it's going to be a very important topic of discussion because, as we all know, that breast cancer is actually the most common cancer of women in India. And I, as a gynecologist, feel that, yeah, initially we used to think that breast cancers were more common in the developed world. But now breast cancer has actually is actually much more common than cervical cancer. And we really need to discuss about it because although the developed world has taken action and with early detection, they've controlled the death rates, but the time that we detect breast cancer in India is much delayed. So, my first question I would like to ask Dr. Ajay Gogia that what is really the burden of breast cancers in India and how is it different from other countries?
Ma'am, the breast cancer in India is recent Globocon 2020. It's usually 2 lakh per year is diagnosed with the breast cancer, newly diagnosed case of breast cancer. So this makes around 10% of the all cancer in India and 26% of the all cancer in women. So it's a very huge burden and it is most common cancer in India right now, leading to all the sites. The breast cancer is most common, even male and female if combined club together is the most common cancer.
Wow. And actually, I think every 8 minutes, there is a death from breast cancer in India, and every 4 minutes, of breast cancer is diagnosed in India. So, and sir, how would you say it's different from other countries?
Well, in the India, the most of the breast cancer present in the advanced or late stage, that's stage 3 and stage 4. That means it's account 70% of the all breast cancer is present in late stage, either advanced stage or stage 4, and 30% in early stage, that is stage 1 and 2. In contrast to Western world, it's opposite. In Western world, stage 1 and 2 constitute 70% of cases and stage 3 and 4 only 20 to 30%. So late stage and early age is the main differences from the West. Usually the median age of breast cancer in West is around 60 to 65 years and in India is 47 to 50 years. So is around 1 decade earlier than the West, and again stage is definitely difference.
So I think the main reason for that is because of the lack of availability and awareness about the screening tests for breast cancer. So I would like you to throw some light on about what are the screening tests available for breast cancer and how frequently should women be doing these screening tests?
Ma'am, it depends on the patient is high risk or low risk. High risk means the patient had family history of breast cancer and patient relative has a breast cancer history. In that cases, every woman should get the screening mammogram at least every yearly. And normal population, the guidelines is every 2 yearly after 50 years of age, mammogram should be done. But in high risk women, suppose is a family history present, BRCA1-2 mutation present, the guidelines are different and it takes 6 monthly interval after the age of 45 years. So it depends the screening methods at what age of diagnosis of relatives, normal population, high risk population, it depends on. But on conventionally, after 50 years of age, annual mammogram is recommended till 75 years of age.
Okay. And mammography is the only screening test that you're recommending?
Yes, well evidence-based practice is only mammogram is the only best mode of screening modality. Second screening modality is MRI, but is only in high-risk women. High risk
Okay.
means is a family history present or
Hmm.
BRCA1-2 genetic test mutation is present and it considered in the one of the modality in high risk women.
And in young women where mammography is not very sensitive, MRI would be recommended.
uh, where the dense is the again the
Density is
difference in the very dense breast and there is a multicentricity. But again, on the screening method, there is a different screening tool of mammograph. Also, there's a digital mammography and there's a screening mammography with a different tomosynthesis. Basically, this is more sensitive than MRI.
okay. Okay. Thank you so much, Dr. Ajay. So, so as a gynecologist, I think we are the first point of contact for all women, and it's very important for us to educate them. And so, basically, because that's the way we give information about the screening methods, the breast self-examination, the mammography. So, I would like to ask Dr. Rupinder on what is the role of gynecologists in the early detection of cancers.
Good morning, everyone. Thank you for having me here. Of course, you are very right. Gynecologist is generally the first port of call for most ladies. So, while you are talking to your patient, it is very important to ask them about the family history. Right? So, any patient having a family history of cancer should immediately put you on your guard and you can ask them about the history of breast cancer. That is most important. Secondly, breast examination. Now, when we are examining a lady in terms of antenatal care or any gynecological problem, we always should do a breast examination. She would willingly submit to a breast examination to a gynecologist, though she might hesitate elsewhere. So that is another thing that we should be doing. Now, to be able to actually detect a lump or any abnormality, all gynecologists should have a basic idea of what they are looking for. Make sure that you are examining the lady when she's sitting. Look for any asymmetry of breasts. Look for the overlying skin. Look for the nipples. Any abnormal discharge. You will get some amount of serous discharge or whitish discharge if the lady is pregnant in any case. But anything other than that, if it's a gynecological patient, then you should be wary of any abnormality and send the patient to the proper clinician. Any bloodstained discharge, any bluey orange kind of skin, any inversion of the nipples. Inversion of the nipples you will come across many times in pregnant ladies. But what you have to look for is that is it symmetrical? Is it there for both sides? Is there any other accompanying lump or abnormality? When you examine a pregnant lady, the breasts are generally dense and lumpy. You should make sure that you are examining these breasts with the flat of your hand and you are not missing out any uh, pathological lump. Up to 20%, that is what the books say, up to 20% of all these lumps which you might just dismiss as a pregnant breast, if I can call it that, or a breast in a pregnant lady, they might actually be pathological. So be very careful and watchful about all of this. You must, I think Dr. Ajay Gogia has very nicely told us what are the guidelines for breast examination in the average risk and normal risk, and also the high risk ladies. So you should be able to advise all your patients as to getting themselves examined. Clinical examination till age 40 is what is actually most important for the average risk lady. Then for the high risk, of course, there are laid down guidelines. It also depends on at what age the breast cancer has developed in the family line of that patient. And depending on that, you start the clinical examination as well as the imaging for that particular person. And whether you are doing an ultrasound of the breast, or you're doing a mammography, or you're doing MRI or a MR mammo or whatever else, all these depends on various factors, which of course is not financial to be here. Then apart from that, self-examination of the breast is not rare in the sense that it has been, various studies have shown that it does not reduce the mortality due to breast cancer. But you can encourage breast self-examination in ladies so that at least they are able to detect a small lump and report to the physician early.
Yeah, I think in a resource-constrained country like ours, we should still, although mammography is the best way of screening, but disregard the breast self-examination. So I wanted to ask you, how often do you recommend breast self-examination for women?
So when we advise our the patients to do a self-examination, what I normally tell them is that please stand in front of the mirror at least once a month when you're having a bath, and look for any abnormality in your breast, because you yourself is actually the best person. You're the best person to know whether there's any abnormality in control, and the rest of it you, of course. And of course, we also tell them that you examine all the four quadrants as well as the axillary trail with the flat of your hand and not with your fingers, so that you know you get unnecessarily alarmed that this might be a lump. So what you have to do is you have to examine with the flat of your hand and press it against the chest wall and examine all sorry all four quadrants of both the breasts.
Okay. And so basically, every monthly they can do a self-examination, and maybe annually with the gynecologist?
Yeah, annually with the gynecologist or with their breast physician, or anybody can do a. You don't necessarily have to go to a gynecologist. Even a family physician can as well do a clinical examination.
Okay.
So
And
they
if
should
they
not.
have a significant family history, when should they start screening themselves? Like how many years before the index case, or is it dependent on the family, the significance of the family history?
See, thumb rule for most cancers is that you start the examination, or rather the screening, as if I might call it that, which it actually is, about 10 years prior to the age at which the family
Index
line
case.
has got the cancer. Yeah.
Okay.
So generally you started that. Then depending on what that age is, like for ladies less than 40 years, ultrasound is a very, very good means of doing examination, which it is much better than a
Self-examination.
mammography, because the breast is that much dense, less than 40 years of age. Subsequently, of course, a mammography is good enough. And sometimes, even after age 40, if the breast is very dense, it is better to resort to an MR mammo rather than an ultrasound.
Thank you so much, Dr. Rupinder. So, as we discussed, it's important, and if we talk about women who actually stay in cities, they do generally come to their gynecologists, and preventive health checks are still some, as people are still aware about the option of preventive health checks. They know what mammography is, but there is a huge part of our population where breast cancer is still considered a stigma. So I would like to ask Ms. Ruby Ahluwalia that how do you try and overcome this stigma that is present in the society with respect to breast cancer, especially in tier two cities, especially in rural areas? How would you deal with that?
Hi, good afternoon. Before I go to as to how do we handle the stigma which is there in the women uh, who are suffering from breast cancer and how the whole society actually looks at it. And I will be talking more from the experience, my personal experience, and also the experience of the people we have worked with till now. So, most of the stigmas are common as far as cancer is concerned. The society does not look at breast cancer differently as such, but they do look at women with women with cancer differently. So some of the things that I would like to talk about, that when a woman gets cancer, the family just assumes that this is not curable, and therefore there is no need to spend money on the treatment, not realizing especially breast cancer and in the early stages is very localized, and it is a huge possibility to get rid of the cancer and be all right for for life. So most of the time cancer and breast cancer is seen as a life threatening disease, which I think it is not. The other is also that it is, in the family it is seen that now a lady has got it, so her daughter will definitely get it. So there is a bit of hostility which comes in the family for the woman, that now she has brought in cancer and now the daughter will also get it, and will go through a similar experience in life. The third thing which I have seen is that most people see that if a woman has got breast cancer, she will not be able to lead a normal married life. And from there, a lot of reactions and the responses which are there from the family and the society, and which create the trauma in the woman. The fourth thing which I have recently noticed and happens most with women who are educated and working, that when they get back to work after finishing their treatment, they are seen as suboptimal workers. So mostly the places where they are working in, they are not seen to be fit enough where they can give the similar output and their productivity will remain the same. A lot of companies these days also lay off women who have gone through an experience of treatment. So, and this happens at very high positions as well. So these are the things which I notice, apart from cancer being contagious, cancer being not curable, which are there, I think, with most of the cancers. And the woman is left alone, actually. So there is a lot of emotional trauma which happens if a woman has to go through a mastectomy. If her stage has advanced a little, then in so many cases the husband and the family deserts the woman, and she's left alone to take care of her treatment as well as her children. So her life changes completely.
And how is your organization helping women deal with this?
Dr. Astha, when I had started Sanjeevani Life Beyond Cancer, the idea was really to close the gaps which are there in the cancer care space. And so one of the projects that we do, which is Cancer Yogi, in which we are in the OPDs of the government cancer hospitals, where we completely handhold the patient in terms of their navigation inside the hospital, dealing with their emotional trauma, by helping them to manage their side effects of the treatment. and also helping them with the relationship issues they experience. So when a woman is completely handheld with a lot of love and care and affection, and that also with people who are trained to do this, especially in the cancer care space, I think it makes a huge difference to the whole dignity, the self-esteem, and the outlook and the attitude of the patient, which again makes a huge difference in the prognosis of the patient. So this is one of the projects that we run. The other is that we work on the immunity of the patients through our project called Satori. These days we are running it virtually, and we work on the patients through their food, breath, and mental constructs. So the kind of bonding which happens with the experts of the organization and all these women who are going through breast cancer is so huge that this is a 36 session course, but even after it finishes, most of the women, they want to remain connected. So we have formed these huge support groups, because we have now worked with more than 3.5 lakh patients, and we try and meet each support group at least once a month. The kind of bonding, and I think the bonding happens because there is a need, because there is a vacuum which is left in their life because of the stigma which is there around the breast cancer. We also run a full-time training program, Dr. Astha, which is to train cancer survivors and their caregivers to become professional cancer caregivers. So a lot of women who have lost their livelihood and have passed their class 10 at least, we run this 4-month training program, and we have already done 9 batches of this, and this runs in collaboration with the Tata Memorial Hospital and Gujarat Cancer Research Institute, BBCI in Guwahati, and Chittaranjan Cancer Institute in Calcutta. So there is 120 hours of theory and 240 hours of practical, so that women who are from the underprivileged background and have lost their families, have lost their livelihood, they are able to get back, number one. Number two, so that we are also able to raise the bar of cancer care in the country, so that cancer care happens through trained personnel. Otherwise, most of the time, apart from the medical treatment which is happening for the patient, most of the other care is coming through people who are philanthropists, or they want to do some good deed on a particular day. It's not happening in an organized way through trained people. So we really want to contribute in that field, and we want to bring in cancer survivors and cancer patients to thrive together, because the kind of empathy they have and also the kind of wisdom they have gained through their treatment along with this training, it goes a long way, because all the people who have finished their course with us have been employed, and there is so much of demand of these people who've been trained by us. And having said that, just one moment more, we also run a special program which is for creating awareness, in which we reach out to colleges and to communities to raise awareness on cancer. So not only on early detection, but also what kind of lifestyle to follow so that your probability of having it reduces. And also how you can contribute if someone in your family or neighborhood is going through this experience. So yes, as far as Sanjeevani is concerned, and apart from all the research we do and the papers we publish and submit, this is the kind of work that we do.
That's really commendable, and I mean, really a lot of compliments to you for doing all this. And you very rightly said you're actually helping in emancipation of the women who suffered. And that was going to be my next question, which you already, I think, said that how is the organization actually coming together to eliminate the burden of gynae cancers and especially breast cancer? So are you also like helping in like early detection, screening, and are you having programs associated with that as well?
These awareness sessions that we conduct, Dr. Astha, I was telling you about in the communities, at so many places, we also take the help of the prevention oncology department of the hospital, wherein they provide us the nursing staff and the doctors at times to help with the screening and the detection as well. So we are trying to do this work. We need to increase it. We need to increase it because awareness is so less, even in the educated. Forget about the illiterate people. You yourself know that even in the films today, whenever they want someone to get out of the story, they will inflict cancer on that person. Not even a single film I have seen in the mainstream which has talked about a person who had cancer and survived and is living a purposeful life. And so this is so hurting actually, that an industry which is the film industry, which can do so much in the field of awareness, have totally shut their eye and in fact doing negative communication on this issue. I think a lot of work needs to be done on this.
True. Actually speaking, if I think in breast cancer, like in most other cancers, early detection makes it almost curable. So if you detect it at an early stage, the cancer is 90% curable. And that's why we are trying to focus on screening methods. But unfortunately, there's less awareness, expensive, and that's why India has a long way to go in that.
Absolutely. Just knowing your normal breast and knowing how does it look and feel is very important for the girls. And that is the kind of awareness we are, because unless and until they know how does the normal breast look and feel for them, it's difficult for them to detect any kind of abnormality. So we're trying to do our bit and trying to reach out to girls at the age of 18 to 20, and of course after that. So yes, this is the work that we are trying to do.
Thank you so much, and it's really commendable work that you're doing.
Thank you.
So, moving on, my next question is to Professor Dr. Malarvizhi. So, what are the physical, emotional, and psychological stress that is experienced by nurses while managing patients with cancer and mainly breast cancer? Because as we discussed, there's so much of stigma, the family starts disowning the patient. So, what do you think that the nurses face while taking care of such patients?
Thank you, Dr. Astha. I'm here. I'm representing as an educator, as a clinician, and as an administrator. I have my handful of students whom I'm just encouraging them to promote this awareness program in breast cancer. And if you just see, I face a major problem both from the nurses side and also from the patient side, where the cooperation is lacking or the gap is there. Because when we teach for our students, we have a stipulated educational protocol what we have to do. There are specializations, training is happening in the college, but when we go to the hospital, there is a lack. There is a lack because the nurses are not there enough to take care of these patients, especially oncology department. I don't know what is the stigma, not only with the patients, it is with the nurses and with the public also, where when we work in oncology we face more problems. So our nurses are also not going to that department, they go to other departments. And most of the nurses, they wanted to go abroad, the attitude is different, where we are not able to get educated, trained, specialized nurses in this area, that becomes a major challenge for us. When that is there, there is a lack of resources, manpower, everything, which plays a major role, because whoever is available in the department, they are being stressed, they have burnout, and they don't have job satisfaction, no time. Even though they are being trained, they are not able to put into action when they are coming with the patients. So this becomes a major role. Apart from that, the physical resources, we say many things, we tell you have to do this, that and all. At times the number of patients are more, and the number of manpower, especially with the nursing profession, it is very less. So they are not able to take care of the other aspects. They just do what is the basic needs of the patient, they will just finish and go. Here basic needs, I tell, the activities of daily living, that is something physical. So here what happens, they are just uh, attending patients more. One patient, one nurse has been given at least 5 to 6 patients. Then they are, by the time they finish this activities of physical areas, then they become tired, the nurses themselves become tired, they are not able to have interest in doing the other activities, especially taking care of psychological and emotional aspects. Sometimes our nurses are also not competent enough, because there is lack of nurses. We take basic nurses who are not well trained in this particular area, then we face problem, because they don't know how to handle the patients, and there is a lack or gap. Communication is a hurdle, and they don't have that emotional stability. So these are all the problems I face. Whenever we train the nurses also, we face a problem here. Now apart from that, we just go to the community also, because of the stigma, because you're a cancer patient, again there is a problem. Now I have a co-education group of students. Now if I tell boys also, you have to go, the male candidates, you have to go and attend breast cancer water test, means first they will hesitate. Second thing, the breast cancer patients themselves are not very happy to receive a male nurse. So now even though we have resources, we are having a gap here, because the patient is not allowing, because they are feeling shy and things. So these are some of the areas I feel, even though we provide as leaders and we are policy makers, whatever we have, even though we have, there is a practical problem in the clinical area, let it be in the hospital or in the community, we face all these problems.
Thank you, Professor Natarajan. So I understand, but that I truly agree with what you're saying, because we also get a taste of what you're saying, that there are a lot of issues which need to be addressed here. So I think I would like to ask Ms. Urvashi Prasad now that as you've heard from Ms. Ruby and Professor Nataraj, there are a lot of gaps, and I think we are really looking for some help from the government in this case. So are there any current policy decisions being taken or planned in regard to early detection of breast cancer? And how are the national programs addressing this burden of breast cancer?
Yeah, so I think policies, we really need policies at every level when we talk of something as complex as this. So, we need it starting right from awareness, prevention, the social stigma aspect, I think, which has been very rightly highlighted, which of course governments can never tackle by themselves. We need a much broader involvement of stakeholders, like we have so many civil society organizations, citizens themselves, sort of speaking up for this. But certainly, government plays a very important role there as well in being a force multiplier. So this is something that needs to be tackled, and sort of reorient our whole focus towards prevention, awareness, health promotion, as well as early detection, because our health system historically has been very cure focused, and still remains that to a great extent. We think of health as something only when we fall sick, then we have to do something about it. So we really need to reorient it, because we have a very large country, and like it was highlighted, that most of these cases are coming at stage 3, stage 4, when obviously it's much more complex to treat them, much more expensive to treat them. So we have, our best efforts have to be towards ensuring that we can pick up these cases as soon as possible, and also health promotion and prevention. It's true with cancer that sometimes, despite your best efforts, you can't really prevent it. But there's certainly certain types of behaviors which can help you reduce your risk. And so it's very important that these behaviors are promoted, awareness is created. And I think with breast cancer, the challenge on the stigma part is also very, very complex. Because healthcare anyway is a field which has a lot of information asymmetry. Add to that, someone who has cancer, which is it's the word itself can be very frightening for so many people. And then if you talk of breast cancer, which also obviously has a gender dimension, then it becomes even more complicated, because women's health, it's not just breast cancer. So many other issues related to women's health are often neglected or not given the kind of importance that they should be. Women themselves sometimes, tend to deprioritize themselves and think more about their families and, people around them. So I think we need to involve men and women in this. Men also play a very important role in reaching out to the women around them, talking about this freely, sort of removing the stigma and the shame element which is often associated with this. So I think those are areas that we really need to focus on. There are some efforts which are being made through the health and wellness centers, for instance, which are being set up, but we have a very long way to go. As I said, it's not just about setting up a new center. It's about reorienting the whole health system, training the human resource. So it's a complex issue to tackle, and this is something that the center and the states have been working on together. So that is one avenue that I feel we can certainly develop, and we can build on it, because these health and wellness centers are supposed to be set up for every 5,000 or so people, and so they can be relatively closer to people. They can be a channel for engaging with communities. So we have to find a way to make them effective. So that's what I would say on the prevention, sort of awareness, health promotion, and early detection side. And I would also say that we do need to look at screening, which is actually scalable, which is cost effective. I agree that the gold standard, might be something, but our country is so large and so complex. If we cannot get that gold standard mammogram or that MRI to everyone right away, we still need to find other means of at least trying to do some sort of screening at scale. So, the breast exam, which was talked about, and we need to continue to innovate and look at other such means that we can develop, which can at least help us identify women who need further investigation. So I think that is another area where emphasis needs to be placed on innovation in this space as well, especially when it comes to screening and diagnostics.
And how are the national programs basically trying to address this?
Yeah, so I mentioned the health and wellness centers. I mentioned Ayushman Bharat. I mentioned the screening that happens, but as I said, there's gaps, there's challenges, and that's what we need to address through some of these innovations, through some of these channels like the health and wellness centers, which can allow us to screen people at scale. Then, of course, on the actual treatment side, there's programs which are there. There's insurance programs which are there. But again, there is work to be done here as well, in terms of what is the ambit of that insurance cover. Like I said, cancer treatment is very complex. It can also involve a number of indirect costs. So when we are covering the costs, what all should we really include? And those are sort of ongoing discussions that happen. But I think that is something that needs to be addressed. Having some sort of standard treatment guidelines in place, which can help us develop these packages under our insurance programs. So I think that is the work that needs to be done when we talk of the Ayushman Bharat or the Pradhan Mantri Jan Arogya Yojana. And then I think from the insurance perspective, then we need to sort of move on to what we call the missing middle. And that is also something that we are currently talking about, because, people right at the top of the pyramid might be able to take care of themselves. Then we have insurance programs being announced for people at the bottom of the pyramid. But there's a big missing middle in India. So these are people who are not necessarily poor or right at the top of the pyramid, but they still don't have that kind of cover, that kind of insurance cover or financial sort of protection. So we also need to address this segment of the population, and that is also something we are doing, is to see how we can extend the coverage of some of the health insurance programs to also cover this large population in the middle of the pyramid.
Yeah, thank you so much. And yeah, because I
Dr.
think even,
Asta,
yes.
yeah, I just wanted to add some point with Ms. Urvashi's points. I just recently was discussing with one of the leader in nursing. I got the information that the nurses are being appointed as community health officers in the health and wellness center for every 5,000 population. So if this is the case, that is also a good initiative by the government of India, where we can utilize the nurses to have this basic self breast examination or awareness programs. We can just have it. That will really make a big difference in early detection of breast cancer, I feel.
Yeah, very right. And actually, I think even the developed world took about 20, 30 years to bring down their death rates from breast cancer. So here being a poor country, we really need a lot of assistance from the government and along with the NGOs and doctors as well. But the government still has to, I think, take a big step in bridging the gap. So I think now my next question is going to be to Dr. Ranga Rao. I let me check.
Yeah, I'm here. Yeah.
Good afternoon, sir. So
Yeah.
I wanted to. So if you could share your views on the best methods of the management for the management of breast cancer, because just to give a broad perspective on what is the basic management like, depend according to the stage.
Right. Yeah, thank you. I've been listening with great interest all the previous speakers. I think everyone has expressed their views. I slightly want to modify your just made statement that India is a poor country. Please modify that. India is not a poor country. I won't say it's a developed country. It is a developing country. There is a gross poverty in thinking, in implementation, in executing. That is what is our poverty. I don't think we have lack of money. If we can dole out free water, free electricity to millions of people, I think we are not at all poor. So I would refrain from saying that India is a poor country. It is not. The other thing is, I was listening to the involvement of the government in this screening. See, though health is the I'm trying. While we are expecting everything to be done by the government, managing from earthquake to the screening, I think there is a need to do a lot from ourselves. I think the health community has to come up with it. One of the points, the insurance. For example, if any middle class lady who cannot afford a screening on her own is not funded by the insurance company, even though she is insured for screening. Now, if this is done, even the screening would help the patient to have an early diagnosis. And if the treatment has to be done by the insurance company, they will fund much less than for an advanced cancer. They don't mind funding a stage 4, lots of money, lots of targeted molecules and so on, but they don't want to fund the simple screening. I think this has to be done, and there has to be a lot of awakening amongst that. We can't expect the government to implement a screening program. It is next to impossible. They have so many things to do before that, much before that, other health issues, many other economic issues. To think of the breast cancer and a screening program, it's whatever they're doing, I think it's fine. But I think we should do a self-breast. A lot of things have been already said. So having said that, coming to the treatment of the breast cancer, I think the important things whenever an oncologist plans for it, it is most important to realize multidisciplinary. No single person, no single specialist do the management of the breast cancer. It is multidisciplinary, which involves the surgical oncologist, the medical oncologist, the radiation oncologist, the imaging person, and another person, that is the pathologist. And so a team has to manage, and of course, the nursing people of good physiotherapists who can educate the patient about the prevention of complications of surgery, a counselor, and then a person who can advise them about the body image and so on. It has to be team management. One single person manage the breast cancer, even if they do it, they claim to do it, it will be highly, highly improper. So it has to be holistic management. That is one important thing. Second thing is, before we proceed to manage the treatment, we must understand two important of the breast cancer, and that is the type of breast cancer, and the next one is the stage of the breast cancer. The type of breast cancer we come to know only when we have a proper biopsy. And a lot of practices which are still in the vogue, maybe by the unaware people, that a breast lump is there and they do an FNAC and they think that this is cancer and they proceed with the treatment. That is unfair. So they have to have, before even surgery, they have to have a biopsy, and then they must know what type of cancer it is, whether it is hormone receptor positive, triple negative, or HER2 positive, because where the timing of surgery varies from different cancers. In different cancers, the timing of the surgery also varies. So maybe we like to give some other treatment prior to the surgery. So these kind of things are very important to know. The second thing is the stage of the cancer. Stage of the cancer is done by the complete clinical examination, whether other organs are involved or not, how extensive are the lymph node involvement, and then after that, we can do scans which are relevant, maybe an ultrasound to the CT scans of the. In some patients, we may recommend these PET scans, though PET scans are not recommended by the guidelines. In India, it is routinely done simply because it is much cheaper, much more cost effective to do PET scans for these patients. So, though it is not recommended as the guidelines, but in some patients, in India, I think it's done. So, in is to understand the type and the stage of the breast cancer, and then we proceed accordingly. The weapons or the tools that we have to treat the breast cancer is, of course, the surgery, is also the chemotherapy, therapy, targeted therapy. Probably it may not be possible to describe all the things in everything. So, but it's a combination, depends on the stage and the thing, we manage that. And the surgery part of it is probably important to understand whether has to be removed or part of the breast needs to be removed. That needs to be discussed by the surgical oncologist or the breast surgeon who is doing the surgery with the patient according to her. As far as possible, the breast conservative, that is keeping the breast intact, should be encouraged unless it is not possible. And if it is not possible in the beginning, then we can give some treatment beforehand so that the size can be reduced. And then similarly, other advancement, and which is now routinely done by most of the qualified breast surgeons, is lymph node biopsy. Earlier, we used to remove the entire lot of the axillary nodes in the axilla, but today only part of the nodes are removed, and that is an important thing. And it's a highly specialized procedure, and this must be encouraged. Both the things are encouraged so that the complications of the surgery are the least in the patient. Otherwise, there will be problems of lymphedema and so on. So, having said that, the chemotherapy, the targeted therapy, the hormone therapy, and so on is a complex process to decide. There was a kind of a sequencing that has done, and it is best sitting down together, and then also understanding the financial aspect, the social aspects, how frequently the logistics aspect, how frequently the patient has to come to the center for treatment and so on. So, like that, it is all decided. So that's about the treatment, very, very just because to discuss not be possible in the short time. And the next important here. So once the treatment is complete, the important need to do the follow-ups of the patient. And the follow-up is done generally in the first 2 years, every 3 months. A complete good physical examination and the minimal investigations are required. And those will depend upon the type and the stage of the breast cancer. And even in the stage 4 of the breast cancers today, especially the hormone receptor positive, we have very good modalities of treatment which have enhanced the life of these patients, the quality of the patients. We are now shying away from giving chemotherapy to each and every patient. We're selectively giving the treatment according to the type of the breast cancer, even in a stage 4. They're also treatable. So in the shorten the whole thing, that the breast cancer management has gone over the whole thing, just removing the breast, and those days are gone. So we understand the type of breast cancer, the stage of breast cancer, and then manage. So prognosis and the outcome of these patients has improved tremendously. So there's no need to lose hope. So though early diagnosis is important, even at the late stages, it can be treated and managed. Yeah.
Thank you, sir. And sir, besides the early detection, what other factors would you say are important in improving the survival rates for the breast cancer?
Yeah, so the treatment has definitely made a huge difference, and then the detection in the early stages. And just to tell you, the average size of outside in the Western world of a breast tumor, when detected, is measured in few millimeters, 5 or 10 millimeters, less than 10 millimeters. Average size of the breast tumor when it is measured in India is almost about 5 to 10 centimeters. So it's a huge thing, and then a lot of educated people. So I think what has impacted the in the West is that early detection and then prompt treatment. And another important thing is most of the patients who are in the rural or semi-urban areas, those people they seek the treatment in the local resources and local whatever medical colleges and so on. Best, but at the same time, a complete awareness of the modern management may not be there. So I can't say, the oncology team exists on every country. It's a far-fetched thing. But as far as possible, the good, knowledgeable, experienced team should be managing this. And even when they were managing multimodal discipline is important. Survival has been changed because of multiple factors: targeted therapy, chemotherapy, hormone therapy, the new hormone therapy, and then so everything has made a difference. Benefits have been seen over the years. Yeah.
Thank you, sir, for such a detailed explanation. And I think it was a very, very informative panel. We had all panelists from all diverse backgrounds, and it was a very good insight amongst all the aspects with regard to breast cancer in our country. And to end this session, I think if anyone or any of the panelists wants to say any last words, please welcome.
So basically, the stage of the breast cancer is more important for sequencing of the treatment. If you detect in early stage, the treatment is surgery followed by chemotherapy followed by radiation. And in stage 3, locally advanced stage, the chemotherapy comes first followed by surgery and then radiation. And in stage 4, as Dr. Rao already enumerated, there is no role of surgery, only tablets or chemotherapy or target therapy suffice. So it's more important to detect stages and the treatment.
Sure. Does anyone else want to add anything?
I also feel, Dr. Astha, that as a system, we need to accept that cancer care is about integrated cancer care. Medical treatment is one of the very important variables in this cancer care, but that is one of the variables, and there are other things which are required to be in place for the medical treatment also to work in the way it is supposed to work. So once all the facilities like the hospitals and the nursing homes, they accept this as to cancer care space is much wider than just the medical treatment, I think it will go a long way.
So true, so true. So thank you so much, all of you. It was really very informative.
And to add that we are having this, the WHO has launched a cervical cancer elimination program. So if while we are educating our gynecologists about cervical cancer elimination, we can add a bit of breast cancer also. That would go a long way in towards early detection of breast cancer.
Yeah, which is very true, because anyways for cervical cancer, they are doing viability and things which
Yes,
will
that's
need a
true.
private space. So the Anganwadi workers can be educated for self-breast examination at the same time.
Yes, yes. And also that every gynecologist, when they are examining a patient, it's
Should be doing.
it should be mandatory to do a breast examination as well. Most of us skip that. So that also can be done.
Yeah. And incidentally, during pregnancy, we pick up a lot of breast lumps, which eventually are turned out as cancerous. So, thank you so much, all of you. It was a pleasure interacting with all of you. And So with this, I would like to end this session, and I'm really grateful to all of you for being part of this discussion. Thanks.
Yeah, thank you for the